Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Urinary incontinence, sometimes referred to as UI, is the loss of bladder control resulting in that accidental loss of urine. Now, women are twice as likely as men to suffer from incontinence, and that's for a lot of reasons: pregnancy, childbirth, menopause, and just because the anatomy of the female urinary tract is a little bit different. The way you were put together is a little bit different than men, and for the most part, it's all good. But the urinary tract, a little more trouble when it comes to incontinence.
Urinary incontinence might be only slightly bothersome for some, while totally debilitating for others. For some women, the chance of embarrassment keeps them from enjoying many physical activities, including exercising. But the good news is effective treatments are available for treating urinary incontinence if women are willing to discuss it with their doctor. Here to discuss is Mayo Clinic urologist Dr. Deborah Lightner. Welcome back to the program, Dr. Lightner. It's so great to have you back.
Very nice to be here. Thanks for asking me.
Dr. Deb Lightner, you have been working on this problem virtually your entire career,
yes.
Right? Does it still surprise you how many women are incontinent and don't seek help?
Yes, it does. There's no doubt about that. Part of that reason is that historically women have had procedures done that didn't last very long. And so my mom had a bladder tie-up. It didn't last. Well, that's just what happens to me as I get older. So that they won't necessarily ask. But most importantly, we don't ask the question either.
Oh, so when a woman goes in for just a regular physical, that's something that's not covered.
Absolutely. Does your bladder give you any difficulty?
So how should a woman approach that if their doctor doesn't ask?
You can easily just say, look, my bladder bothers me. It's more common than hypertension. It's more common than diabetes, and we don't necessarily ask the question. A woman should ask.
So we established that incontinence is a problem, but there are different types of incontinence.
Yes.
So let's talk about that.
Absolutely. So the one that you kind of alluded to earlier when you're discussing this was about women are built differently. We have pregnancies, we have significant stressors that are placed on the pelvic floor as we have a child come through the pelvic floor. And those stresses, those stretches, may not give us stress incontinence at the time that we have our babies. We may get better from it, but then once we hit our 50s, we start to have more leakage with activity. That's called stress incontinence. That means stressors on the pelvic floor make the pelvic floor open up, and then you have urinary incontinence. But there's another very, very important type of incontinence that probably affects people's activities of daily living much more than stress incontinence, because stress incontinence I can predict. I know that if I cough or sneeze, I know if I do a jumping jack, or if I go on a trampoline, oops, don't go on a trampoline. That's stress incontinence. I can predict it. But what about the leakage that I can't predict? I'm standing in the grocery store in front of the lettuce, and all of a sudden my bladder says, gotcha, and I pee and I fill my shoes. Now I'm not going to go out to dinner with my friends. I may not go shopping. I may not be able to sit through a movie if I go out with friends. That kind of incontinence, called urge incontinence, is much more onerous to activities of daily living, much more disruptive of what you like to do. Will keep you from traveling, will keep you from visiting friends.
Which one is more common?
Urge incontinence.
Okay.
Is it really?
Urge incontinence is much more common, and the reason is it is much more prevalent as we get older. So stress incontinence, you've had a stretch to your pelvis during childbirth, or maybe you're overweight, maybe you have a chronic cough, and that's going to usually happen in your 50s and maybe your 60s. I can help you a lot with that by just teaching you where your pelvic floor is and strengthening that. Kegel exercises. But the urge incontinence is much more common in men and women as we get older. Much more common in both genders.
So you talked about pregnancies and age being risk factors. What are the other risk factors that might let women know that they are more likely to develop an incontinence, either type?
Well, with stress incontinence, there is another thing. I already mentioned about weight, overall healthy weight, having a good muscle tone, strength. But there are also a group of women who are much more likely to develop stress incontinence, as well as prolapse, things falling down, and that is if they have a lot of joint hypermobility. So if they have very, very stretchy connective tissue, and there's some tests that we can do very easily in the office that will show you whether or not you may be a person who's also at risk. That also tends to run in families.
Wait a second. While you were telling us that, you were just pulling on your
Your
finger
fingers.
and putting your
I
finger back.
was.
So if you have stretchy joints,
If you're the rubber jointed woman, okay?
okay, I'm trying to push my finger back.
Okay. Yeah, exactly. You can get your little finger back to 90 degrees.
Yeah.
Okay.
Is that good or bad?
That's I'll tell you. I'm gonna hold off on answering that for just
Okay.
a second. So now the other thing is, can you bend your thumb down and touch your wrist? Aha.
Pretty
yeah, I
close.
certainly can.
Mm-hmm.
And now stretch your arm out.
Okay.
And is your elbow flat at 180 degrees, or is it more than 180 degrees?
I think you better make an appointment.
I guess.
Okay, so joint hypermobility is associated with stretchy connective tissue. You have babies through the pelvis. Your connective tissue tends to be stretchier. Now, that puts you at higher risk for prolapse, for stress incontinence, but it also means that you're going to be better at gymnastics, those sorts of things.
Is that true?
Yoga.
Good. That's what I'm going to do.
Actually,
pretty good.
yoga, those sorts of things. We're also much more commonly have orthopedic injuries because what'll happen is you'll come down, you'll do a layup shot, you'll come down on your ankle, you'll twist your knee, you'll overthrow your shoulder. Those sorts of orthopedic injuries are very, very common in this group of people, and it tends to run in families.
Sorry, did I miss it? So if you have hypermobility of your joints, are you more likely to have stress incontinence or urge incontinence?
Stress
Or
incontinence.
Stress incontinence.
And pelvic floor weakness, pelvic floor prolapse.
I would imagine then you team that up with having a couple of kids, and I should probably make an appointment with you.
Only if you have symptoms.
Okay,
That's
very
it.
good.
That's it.
I'll just keep your number on my
Okay.
Rolodex. All right. So if you have stress incontinence, are you more likely to get urge incontinence too, or are the two of them completely separate?
They are related, but think of them as separate, so that it really depends upon which is the most onerous to you, which bothers you the most. For many, many women, it's the urge incontinence that bothers them the most. Now, if you like to play tennis and you can't serve without having leakage, that's stress incontinence, and we may want to address that further with behavioral treatments and sometimes with surgical procedures. But I would also like to stress that if you come in to see me and I immediately say a surgery rather than behavioral, you should say, I think I'll go see someone else.
That's
You
right.
wouldn't do
Second
that.
opinion. Yep, absolutely. We're with urologist Dr. Deborah Lightner, and we're talking about urinary incontinence in the female. We have been told that there are two different types of incontinence: stress incontinence, urge incontinence. Urge incontinence being much more common than stress. We've talked about the risk factors: children, obesity. Did I miss anything there?
Chronic-
Hypermobility.
Hypermobility, chronic cough. If you're just not healthy, if you just aren't strong, that's going to put you at risk for stress incontinence as well.
And of course, aging. As you get older, this is a problem that's much more common in the older woman. than
Privilege.
men. Yeah.
A privilege of
yeah,
aging.
Yeah.
We're going to take a short break, but when we come back, myth or matter of fact, Americans should drink 8 glasses of water a day. Is that a myth or is that a fact? We'll find out.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
We are with urologist and female incontinence expert, Dr. Deb Lightner of the Mayo Clinic, and we'll start off with myth or matter of fact before we talk about the treatment of this most common problem.
Yeah, myth or matter of fact, Americans should drink 8 glasses of water a day. Is that a myth or is that a fact?
We've heard it time and time again.
That is a myth.
Why?
Okay, it is important to have a healthy diet, but that 8 glasses of water, 8 ounces, 8 glasses a day, translates directly into 8 voids, because
It's a lot
a
of
bladder
water.
holds about 8 to 10 ounces. So that if you drink that much water, you should expect that you should have at least 8 voids. Now, what we would really hope is that most of the fluids that you get are in fruits and vegetables. They're about 80% water. So that is going to contribute to your overall hydration during the day. Many of the patients that I see with urge and urge incontinence have it solely because they are compulsive water drinkers.
So the fact is that you should drink when you're thirsty.
No, that's actually not a great idea either, because unfortunately what happens if I tell somebody to do that and they're used to drinking 8 glasses of water 8 ounces. They carry a water bottle around with them always. And I tell them, no, let thirst be your guide. They're already habituated to that high fluid intake, and they think, well, I got to drink. I'm dehydrated.
They get thirstier faster.
They get thirstier faster because it's become very habitual.
Okay, then is it the color of your urine that should guide you?
No, the color of your urine isn't a good one
We're
either.
going to get the right answer here pretty soon.
We're
Yeah,
dispelling
exactly.
myths is what we're doing.
The reason is that many of us are taking multivitamins, and those multivitamins may color our urine. So yes, that is true. If you have, particularly if you make kidney stones, there are some medical conditions when you should be drinking extra water, and kidney stones is one of them. So we'll routinely tell those people to have their urine be clear. But you and I do not need to hydrate to that degree.
All right, so
So what's the answer? Yeah, what are some guidelines for drinking water?
Water, I don't know that you have to drink any additional water for medical reasons alone.
All right. Well, that's good. 8 is way too many, unless you are a kidney stone former.
There are some medical reasons why doctors will tell you to drink extra fluids, but that's not what we're talking about here. The majority of the people that I see don't have a medical reason to consume as much fluid as they do.
So whether it's stress incontinence or urge incontinence, let's just back up even further and just say, what is normal? What is normal?
Normal people void 6 to 7 times a day, 8 to 10 ounces each void.
All right. 6 to 7 times a day, 8 to 10 ounces per.
I'm not measuring.
Yeah.
I'm
But you
just
don't-
thinking, how many times do I go a day?
But you don't need to measure. That's the whole point. That's the beauty of the way our bodies are able to metabolize fluids and keep us healthy, is that our bodies, our kidneys, will normally regulate the fluids that we, normally regulate the urine production that we make based upon our intake.
All right, so we got to talk about treatment. So we know this is a common problem. When we talk about treatment, do we need to divide it up into stress and urge, or can we talk about treatment for both of them at the same time?
Behavioral treatment is the primary way to treat incontinence, regardless of its type.
All right, behavioral. All right, let's start. How do you, Kegels, which is it?
Sure. Actually, the gynecologist who first described that passed away many, many years ago, so I'm not sure how he pronounced his last name, but we usually say Kegels.
Okay,
So,
tell us about those.
Well, Kegels are useful for women because they strengthen the pelvic floor. And most of us were kind of taught, oh, you pat it on the back, go do your Kegels, come on, go do your Kegels. But we actually never tested to see whether or not a woman could identify her pelvic floor, how strong the contractions were, and what kind of endurance they had. So that during a routine physical exam, what I'll do is I'll say, I'm going to put my finger in your vagina like a tampon, and then I want you to squeeze those muscles as if you're going to interrupt your stream, or as if you're going to keep yourself from passing gas. And what you'd like is to be able to have at least a 2-second hold with some additional lift. Okay, so who cares? I can do my Kegels. Yay, that's good for me. But I should use those Kegels when, for example, I cough or sneeze. Just as I would cover my mouth, I'm going to do a Kegel and tighten that pelvic floor to reduce the likelihood that I'll have stress incontinence with that
that's
activity.
behavior, behavior modification.
More importantly, so you're standing in lettuce, you're standing in the grocery store near the lettuce, and your bladder says, I gotcha. I'm going to soak your shoes. What you do first is you don't run to the bathroom, because that's like trying to run with a full glass of water. You're not going to make it.
Right.
Okay? What you do is you stop and you do a series of what we call quick flicks. With your pelvic floor, you say, no, no, no. I told you no. You're squeezing the pelvic floor rapidly. And what it does is through the sacral arc, through the lower spinal cord, it will turn around and tell the bladder, okay, not right now. And your urge will disappear. And then you can safely go to the bathroom and void.
Is the same thing work for men?
Absolutely.
Yeah.
Only in men, we don't call it Kegel exercises, because he was a gynecologist. We call it Janets, spelled like Janet, but with the little French, yes.
Oh, really? But it's the same thing.
It's the exact same thing. And men are worse at doing Janet exercises than women are at doing Kegels.
Really? They're just not very responsible, are they? But you know what? We don't buy lettuce. So for us,
That's
it's not a big problem.
That's it.
I'd say if you have a leaky bladder, that it becomes pretty important really fast.
Yes. Well, for men don't leak. Men, for the most part, have the urgency, but they don't usually have the leakage. Women leak, again, because of that difference in anatomy. Men have extra apparatus there that keep them drier than
Sure.
We are.
All right.
Okay, let's, we
more
gotta-
treatment options. So if
right.
you've got behavior modification with the Kegels, what else?
I'd want to look at your bladder diary. Very important. Before I see anybody who's got bladder symptoms, I want a 2-day bladder diary. I want to know what they're drinking, and I want to know what they're voiding. Importantly, I want to know how much they're voiding, what their inner void interval is, and how many of those activities are related with leakage. That will help me make the diagnosis and start right then and there discussing how we're going to modify behavior.
And how do you do that? The things that we've talked about, but if all that isn't working and they're still incontinent, then what do you do?
So incontinence with stress incontinence, and it's really bothersome to your activities of daily living, your Kegels are good and strong, then we're going to talk about some other options, whether that's bulking agents or slings or those sorts of surgical procedures.
You said before the break, though, that if you go to see any urologist and they start talking about
Or
surgery right away,
gynecologist.
then they start talking about surgery right away, then you're in the wrong office.
I think so.
All right, bulking agents, start there, and then
Sure. Bulking agents is just the injection of material around the bladder neck to literally kind of poof it up and make women less likely to have leakage. It's rarely effective in men. But the problem with bulking agents right now in 2017 is they just don't last. There is something on the horizon which won't be ready for me, but perhaps for others in the future, and that's where we can actually grow muscle, your own muscle, from a biopsy, and grow it in on a plate, have it sent back, and then I can inject your own muscle into you that will actually function as an augment to your sphincter and reduce your stress incontinence.
and it's an injection. I
Yes,
mean, it
it's
doesn't
an injection.
require a
Nope, not a
wow.
surgery.
And then when might that be available?
It's
Tracy will
right
still
now.
be
It's
around.
exactly.
Yeah.
It's right now in clinical trials.
Oh, no kidding. All right, so that's an option. What else?
Sling. So that we talked a little bit about in terms of the pelvic floor supports not being perfect. And so when the pelvic floor rotates down and the bladder neck opens and then you have leakage, you can place materials around the bladder neck to create a hammock to make you less likely to have urinary leakage with activities.
Successful most of the time?
Successful most of the time.
But
All
do
right.
the behavior modifications get you?
Behavioral modifications are primary. Absolutely. 60 to 75% of women will find that the leakage that they have no longer bothers their activities of daily living if they use the behavioral techniques we described.
Wow, pretty incredible. Urologist Dr. Deb Lightner, also incontinence expert. Thank you so much for being with us.
My pleasure. Thank you for asking me.